There's another study. This is a really curious study from Mexico, and what they did was a randomized trial of passive turning and mobilization. Now these were acute stroke patients, I think in Mexico City, who were in general medical wards, and most of the care, the hands-on care, was provided by family members. But what they did was they had a program of training the family members in good positioning and mobilizing, and they supervised them in that. And in this study they found that the chest infection rate dropped, was halved in the group who got the turning and mobilization. And again, it just, I think, reinforces the importance of good positioning and mobilization. And the last one was a project that I was involved in. We have a PhD student, Louise Craig. She's a physiotherapist, and we're working together with Julie Bernhardt in Melbourne, and we combined information from the original the AVERT early mobilization trial pilot study, and one that we did in Scotland called the Veritas trial, which had an early mobilization component. And when we put the two of these together, this has just come out in stroke, we only had 100 patients in these studies, but there was a significant reduction in complications of immobility among the early mobilization group. And one of the key reductions was with chest infections, which were almost halved in the early mobilization group. To be honest, this has come as a bit of a surprise to us because, I mean, the control group were getting good stroke unit care, and you know, there was still a reduction. Again, I think that we need to see the results of the main AVERT study, but I think it just illustrates the importance of good mobilization. So just moving on then to the next category. This is infection, urinary tract infections. These, again, I'm sure you're aware, quite common, particularly seen in people, more severe stroke in women more than men, and there is an association with urinary catheterization. And when we looked at the predictors, we found pretty much the same thing: severe stroke, females more than males, and catheter use were the big risk factors. I mean, I don't think there's anything terribly surprising in the management. It's good fluid management, trying to avoid urinary catheters if you can. Query cranberry juice. The evidence for cranberry juice is a bit variable, but it tastes quite nice, especially in a sea breeze with vodka. And possibly early mobilization. I'll come back to that. And I'm sure you're aware that, again, the crucial thing is to think of it. If you think of it, you'll make the diagnosis and you'll treat it. And this is an area, I think, where our again, I've seen with our multidisciplinary team, it can work really well when the OT, for instance, working with a patient and says, you know, they're just not right today, and that alerts people to think of urine infection and something that's just knocking the patient off the best. I mentioned mobilization there, and in that same small study, or two small studies of very early mobilization, we also found a drop in urinary tract infection, which I find hard to explain, but there it was. I'd say we need to wait for the main AVERT study, I think, to see if really this is a true effect. People have argued, well, if these infections are so common, why don't we just give everyone antibiotics and prevent infections? This suggestion usually gets your infection control people in a spin. But there have actually been 4 trials, clinical trials, looked at just routinely giving everybody antibiotics, and they've used different kinds. And definitely you can prevent infections, but it's not at all clear if it really makes a difference in terms of recovery. And most places I'm aware of, it's just the clinical team being alert to the possibility of infection. Falls, I think this is a really common feature in rehab. Again, I don't need to tell this audience how important falls are. What surprised us when we did our original study was how frequent reported falls were once people went home. Fortunately, they were often not associated with serious injury, but they probably were associated with loss of confidence and loss of activity. Currently, I think the main way of managing falls in the stroke group is the same as in the frail elderly. The sort of people who are at risk are those with the more severe disability or severe impairment as well, especially balance and leg strength, and people with cognitive deficits. And usually we're going for a kind of multifactorial risk management, reducing unnecessary drugs, physio to improve balance and leg strength, OT assessments to especially environmental assessment to make sure that the home setting is safer. A related one here though is osteoporosis. And this is recently been recognized as very common in stroke patients. Firstly, this age group are a group who are at risk of osteoporosis, but after a stroke has happened, there seems to be an accelerated rate of bone loss, which is probably down to immobility, but may also be to do with vitamin D status. And interestingly, it's asymmetrical. It's worse on the hemiparetic side. So it does seem to relate to movement as well as sort of more systemic things like vitamin D status. And the treatment, I think, is very much conventional. There's nothing unusual about stroke patients. The one caution might be that some of the oral bisphosphonates are rather difficult to swallow, and if you've got an impaired swallow, that might be a factor to take into consideration. I don't know in Tasmania if you need to help cope with poor sunlight. In Scotland, you certainly do. So we use quite a lot of vitamin D and calcium, and we do use the bisphosphonates in those people who've got really significant osteoporosis. Pressure sores, of course, these are unheard of in our own unit and common in everyone else's. But it was actually quite sobering to do a systematic survey of everyone admitted, consecutive people, finding up to 20%, mercifully not with severe things like in this picture, but with skin breaks or skin changes of some sort. Once again, it's the same story. Older people with severe stroke are the ones really at risk of this complication. I think it's one area where there's actually quite a good amount of research demonstrating the pressure relief measures really do help prevent and treat prevent and treat pressure sores. And again, it's the same kind of story. Stop me if I'm boring you, but the importance of good multidisciplinary care, because it's about good positioning and turning and moving and avoiding prolonged bed rest. Now, here we come to one that's become very confusing. Venous thrombo-embolism, which is really taken to be DVT and pulmonary embolism, has long been recognized as a risk, that stroke patients are at risk of these complications. And how much at risk, how common these are, depends on all sorts of things. And it's very difficult from the literature to get a clear answer. But clinically apparent DVTs are not all that common. So if you don't ever scan anyone, you don't seem to see very many. If you do a systematic scanning of people with, say, a Doppler ultrasound of the leg, it's probably about 1 in 10 have a DVT. And some of the older studies that did very sensitive scanning techniques that are now no longer used, they reported up to 1 in 2 stroke patients having DVT. Having said that, you know, this was done in the 70s, and this may have been associated with bed rest. And similarly with pulmonary embolism, clinically apparent pulmonary embolism is pretty uncommon. But if you look at autopsy series, people who die after the stroke, a very high proportion will have evidence of pulmonary embolism. So we don't really know how common pulmonary embolism is. Now, all our guidelines at home had recommended thigh-length compression stockings until less than a year ago, when the CLOTS trial, this was a study looking at the value of thigh-length or knee-length stockings, and basically it found no benefit. There was no significant reduction in DVTs by using thigh-length stockings, and knee-length stockings weren't as good as thigh-length. So basically there was no group of patients seemed to benefit from DVTs. And slightly worrying was there was a significant increase in skin breaks and skin injuries associated with stockings. And I think you can see here this person had a short stockings, and it's got a little abrasion there. So I used to enthusiastically encourage the team that we should be using compression stockings, and now we've had to abandon them. And of course, if they hadn't had a stroke, you would be thinking about anticoagulants. But in this acute stroke phase, there is a trade-off between benefit and harm, the bleeding risk of anticoagulants. Aspirin definitely does reduce DVT risk, but it's not particularly powerful. And there's a whole load of things that we think are important to do with hydration and mobilization, but are essentially unproven. So we're in a slightly awkward position with this at present. So that was the group, the complications of immobility. But as you move further down the patient journey, there's particularly another group of complications come along, and I'd like to just finish off with these. And particularly we're thinking about conditions such as depression, anxiety, emotionalism, and pain. I see there's a bit missing from the fatigue. We didn't measure fatigue in our study, but I'll come back to it. This is something that's become much more recognized in recent years. But I just want to briefly mention these. And